Thank you so much for having me. I am really excited to talk with all of you guys about the Family First Prevention and Services Act. Let me see here. For some reason, my clicker wasn't connecting. Oh, there we go. So let's talk a little bit about the Family First Prevention and Services Act, and we'll try to set a foundation for why we are here today. So originally, when the Family First bill was introduced, it really was talking about the structure of child welfare and why child welfare needed kind of a revamp in the way that we look at the way that we work with children and families. And so that's really what the foundation of the bill is that thinking about families first, hence the name of the act itself, and the way we interact with them. So historically, just to give you a little bit of a foundation, the way that we have drawn down funds from the federal government is whenever a child or youth is placed outside of the home, we would draw outside of their home in what you guys know as congregate care or group center care or residential treatment care. We would draw down money for those placements itself. So the Family First Prevention and Services Act really changes that to say we want to work with kids and families before they are actually placed outside of the home and focus on preventing that out-of-home placement. As all the research tells us is that families do better when they are together or they are with kin-like placement. So that's really what Families First is about. It's really exciting legislation. It's a lot of work, but it really is about doing what we know works for kids and families. So just to give you a little bit more information about why Family First Prevention and Services Act was passed. So we'll talk about substance use, so specifically opioid. So as you guys are aware, and it's in the news all the time about the opioid epidemic across the United States. So Family First also has a huge piece about addressing that opioid use and abuse across the United States. So how do we put our families first and address opioid use without necessarily putting kids outside of their home? How do we keep them together and keep them safe in a way where it's the least restrictive or family-like settings? So here is really a organizational chart about how this work is happening in the state of Colorado. So we have been doing this work for about the last 2.5 years. So when the Family First Act first was even introduced, Colorado was very quick to say, hey, we want to do this and we want to be one of the leaders in this. So we've put together an implementation team, and as you can see, we created a work plan. So Casey Family Programs worked with Colorado and did a strategic planning session and created these work groups to talk about all of the different folks that would need to be a part of the Family First Prevention and Services Act. So one of the reasons that I have been tasked with talking about Families First, and my office really works hard on the collaborative management program, is because the collaborative management program touches 10 systems. And we know that we cannot implement Families First without our partners. And that's why this work is so important, is that we engage our partners in this. So as you guys do with the Office of Behavioral Health and the Behavioral Health Task Force, we have had to partner very closely to know that this is going to work well with not only our juvenile justice partners, but our mental health partners, our behavioral health partners, our partners in service providers across the state. So you can see there's a lot of folks working together on this. So the Family First Act is actually broken down into two titles. One is about placement prevention, and one is about making sure that it's the appropriate placement. So we'll talk about both of those, as well as Colorado's response to those placements. All right, so the goals of the reform is really about preserving families. How do we keep families together in the least restrictive settings? How do we address substance abuse, as we know that that's the major reason kids come into foster care, is parental substance use? And then we really focus on getting incentives right. So prevention services are at the front, up front end of all of this. And then we want to pay for what works. So in order for us to serve a kid or family, there has to be an evaluation and of the programs that we put into our plan. So Title I is really about prevention, which is the best part about the Act. So I don't think there's a person that works in this space that does not believe that prevention works for families. And so we get really excited about when we talk about prevention. So in order to serve a child or youth or family through the prevention services, we had to figure out our definition of a candidate. So each state has to put in their prevention plan, what is a candidate for foster care? So in Colorado, we wanted to think about candidates in a really broad scope. So, the most likely candidate for foster care, and as you can see on the screen, this is our actual definition, but I want to explain it in a way that kind of makes sense to folks. So a candidate for foster care would typically be someone with an open child welfare case or open referral. And that's what we're calling the folks that are in our house. And so we can serve those very easily and quickly, but Colorado said we can do better than that. We want to serve not only the kids with the open child welfare referral and an open child welfare case, but we want to serve the kids that are in our porch, not just in the house. So we talked about, can't we serve kids and families before they actually have an open case with child welfare? So we want to serve all of those kids that potentially could become child welfare clients. So that looks like kids and families that would be eligible for services. So in Colorado, we've had prevention funding for quite a long time through our core services program, our collaborative management program, and you can also use some of their child welfare block funds. So saying, you know what, we want to prevent out-of-home placement for this family. Let's go ahead and serve them in a PA3 case or a prevention case. And so that would be our kids that are on the porch. Colorado said we can even do better than that. So we want to serve the kids and families that are in our yard. Those are the kids and families that maybe touch the Office of Early Childhood. We talk a lot about kids and families that are served through not only the Office of Childhood, but also the Office of Behavioral Health. Sometimes those kids and families end up becoming child welfare clients because they need more than what they currently are getting, or they're afraid to go into a mental health center. So we said, how do we serve them in a way that makes sense in a prevention manner, and we can provide this service for up to 12 months through Family First. So we're really excited that we have an opportunity to provide some funding to these programs so that we can serve them before they become child welfare clients. So what has to happen? So the state has to submit to the federal government a prevention plan. And then this prevention plan, we have to talk about how are we going to serve kids and families in a promising, supported or well-supported program in Colorado. So that's what we have to look at, is that we want to put in our prevention plan programs that meet the standards of well-supported, supported, and promising. When this act first passed, they said that 50% of the programs had to be well-supported. There was an act that recently passed as an amendment to Family First that said now we can do 50% of our programs as well-supported and supported until 2024. So we have to develop a plan, submit it to the federal government saying, what programs do we want to serve kids and families through these programs? How are we going to put a risk assessment in place to say whether these kids and families need those programs, the evaluation of the programs, monitor the programs, and then provide training on how to use these programs. So in our state prevention plan, it has not come out yet, but it will come out for public comment. And it talks about all of the programs that we will be putting into place. So some of so the federal government created a clearinghouse, and in that clearinghouse, they had 12 programs that they consider well supported. Of those 12 programs, Colorado is currently putting in 9 of those, including multisystemic therapy, functional family therapy, and like I said, I'll show you all of the programs that are in there, but of those programs that are in the prevention side, we can draw down 50 cents on the dollar for every one of the prevention programs that we fund. So we're really excited about that because we can draw down funds in a way that prevents kids and families from coming into foster care, according to our definition of a candidate. So we're going to get reimbursed for kids and families that we're serving in a prevention way rather than just in a placement way. So what do these prevention services look like? So they have to be in 3 buckets. So it has to be a substance abuse prevention program, a mental health prevention program, or a parenting skill-based program. And you can see that parenting skills is actually broken down into not only parent training, but also parent education and then family counseling. So we're excited about that because we know that in all of these 3 prevention program areas that we can really serve a lot of kids and families. So what are the requirements of these prevention programs? It must be trauma-informed. So as you guys are aware, trauma-informed was kind of the buzzword for the last few years. And you know that trauma-informed hadn't really necessarily been defined in the state of Colorado. So we turned to our friends at the Office of Behavioral Health, and they helped us create a definition, which I'm going to show to you later, that will be the same definition for our prevention programs that we're using for our residential treatment or QRPT programs as well. So we did, in the work that we've done in the last few years, define what trauma-informed means, and there will also be a certification process that happens through the Office of Behavioral Health that when you are a trauma-informed program that you receive this certification. So once again, it has to have a designed a rigorous evaluation. So we have picked or partnered with DU and the Colorado Lab, who will help us do our evaluation for the Family First Prevention and Services Act. So that's a little bit about Title I, which is really exciting and really talks about the prevention side of the Act. Title II is about appropriate placement. So Title II actually creates a new kind of placement, which is called a QRPT, or Qualified Residential Treatment Program. So in order to be served through child welfare, you will either have to be in a foster care placement or in a QRPT level of care. So once again, the recertification process will happen. There are many programs that have already applied to be a QRPT, but there are a lot of things that need to happen for you to go from a regular congregate care placement to become a QRPT, and I'm going to talk about what those requirements are. So this is actually your definition of a trauma-informed treatment model. So in order to become a QRPT, you have to follow the trauma-informed treatment model. And once again, this is the same definition for our prevention programs as well as our QRPT. So not only do they have to be trauma-informed, which is just great practice across the board, but they also have to have a registered or licensed nursing staff available 24 hours a day, 7 days a week. So this is specifically in response to the over-medication of youth that has happened across the United States. And so this is our way to say, we really want to monitor the medications that our youth are on that are in this level of care, and how do we do that in a really thoughtful way? So that, that licensed nurse has to be available 24 hours a day, 7 days a week. It also really facilitates treatment plan in a wraparound sort of model. So historically, when we had a youth in conflict case and they went into a congregate care level of placement, we developed a treatment plan just for that youth. Through this QRPT level of care, not only do we have to serve the youth that is placed, but also their siblings as well as their family. So all of the participants every person in the family has to participate in a treatment plan if a child is or youth is in a QRPT level of care. So they have to not only do that, but they also have to, when they leave the QRPT level of care, they have to be served with at least 6 months of post-discharge planning. So what does that look like logistically for you, those of you that know? If you have a young person that lives in Colorado Springs and then they are placed in Denver, they typically would go back to Colorado Springs, and if they could, they would start some treatment afterwards. However, this legislation says that let's just use MST as an example, since we know that that's one of the evidence-based programs. So if they are placed here in Denver at, let's say, Denver Children's Home, and then they go back to Colorado Springs, and MST services cannot start for 2 weeks, Denver Children's Home would then have to serve them at least for those 2 weeks until the program can pick up in the spring. So really there has to be a continuity of care that happens, and the QRPT has to provide that care for them during that transition period. So there is a lot of things that are putting on these providers to become a QRPT, but all of them are put on there because they make a lot of sense for kids and families. So the licensed nurse, the treating the whole family as a whole, and really making sure that those aftercare services are in place. So what needs to happen for a child or youth to go into a QRPT is very different than the way that we have done historically residential treatment homes. So in order to go into a QRPT level of care, we have to have a qualified individual who is a neutral assessor do an assessment that says this kid or this child or youth meets the level of care to go into a QRPT. We are in the process of figuring out who these qualified individuals would be to do this neutral assessment. So that is some of we've been partnering with the Office of Behavioral Health to figure that out, and it's a continued conversation. And one of the reasons that I'm sure you all saw the notification that Colorado is going to delay their implementation, this is one of the reasons that we really had to delay, is we had to really figure out who this neutral person would be, because the federal legislation says that it cannot be the child welfare agency, and it cannot be the person or the provider receiving the child into their care. So we need to really be thoughtful about who this qualified individual will be and how this can happen across the state of Colorado. Because as most of you are aware, to serve a kid in Baca County is very different than to serve a kid in Denver County. And so we need to make sure that this works and be really thoughtful about our implementation around that. What we have determined is the tool that we will use to determine the level of care. So the tool that has been determined is the CANS, which Dietrich is going to go into a lot of detail about as soon as I kind of get through my portion. I want to give Dietrich plenty of time to talk about the CANS. And the CANS stands for Child Adolescent Needs and Services Tool. It's a tool that the Office of Behavioral Health has been doing for a really long time, and Dietrich is our state expert on that. So she's going to give you a ton of information about that. So in order to go into a QRPT, we have to have this neutral assessor do the CANS along with what we call a family engagement meeting or similar type of meeting, and then make a recommendation to the court. And the judicial officer will then make a finding to say that, yes, this kid will be going into this level of care. So, of course, judicial officers have the authority not to follow the CANS. We believe that, if they don't follow the CANS or this neutral assessment and the assessor, along with a group of folks, that we're going to have to figure out how that would be paid for in the state of Colorado, because we know that we will not get federal reimbursement for these placements if we do not follow our level of need tool and this assessment process that's been laid out in the legislation. So the final thing that needs to happen is that we also have to make a judicial finding that says that there will not be a negative impact on our commitment rate to the Division of Youth Services. So what that means is that we can't commit more kids because we cannot place them in a QRPT level of care. And so we have to make sure that there's not a negative impact on our Division of Youth Services. So all of that being said, there are certain limitations around QRPT level of care. So children and youth that do qualify for QRTP level of care is children that are victims of sex trafficking, that are prenatal, postpartum, or parenting supports for youth. So they are really folks that we think about as that they would qualify for a residential, this QRPT level of care. So I think best practice across the board is that this neutral assessment would happen before they actually get placed. As many of you know that have done child welfare, is that we oftentimes place kids in an emergency situation. So we have that 14 days to do this assessment once they have been placed, if it happens in an emergency situation. So this slide actually says planned congressional action, but this action actually passed last week, so we're really excited about this. So initially, I think there were a lot of states that said, we really don't know how we're going to build up our prevention programming at the same time we're making our QRPTs, which would reduce our out-of-home placements. So we don't really know how we're going to ramp up our prevention and kind of minimize or get the right kids in the right level of care all at once, because that's a lot of things to happen, and meet that well-supported level of prevention programming. So we were in support of this congressional action along with many other states that says that we can delay the 50% of the well-supported programs until 2024. So we now get a count not only well-supported, but supported towards our 50% match. So 50% of the programs that we put in our prevention plan can not only be well supported, but now supported. So we're really excited about that because it is potential to expand our prevention programs to more across the state of Colorado, because really our big 11 counties are the ones that do the well-supported programs, and we know that we need to serve the kids across the entire state. So we need to figure out what that looks like for everyone. And then there was also $500 million that there does not have to be matched for all of the states across the nation. So our portion of that in Colorado to implement Families First is $7.7 million. So we're excited because that really gives us some structure to implement Families First. So collaboration, as I said before, is really this is not just child welfare legislation. This is about, we're going to have to work with our judicial partners and many other partners. So Colorado has done a lot of things to lay the foundation to implement some of this work. One of those is Senate Bill 254, which is a cash fund for prevention services, specifically for what we call our balance of state counties. So the Senate Bill 1308 gave our balance of state counties, which is not the big 11 counties in the metro area, but those smaller counties, ways to intervene and put in placement prevention services. So the adoption of evidence-based services is something that Colorado has been doing for quite some time, but we really will continue to ramp that up through Family First. So this is a video I'm actually not going to play for you today, but I wanted to make sure that you had this video. So this is Minna Castillo-Cohen, who is the director of the Office of Children, Youth, and Families. She partnered with Judge Furman from the State Court Administrator's Office. It's about a 12-minute video, and it really talks about some of the things that we've talked about today, but it really talks about the partnership and why it's going to be so important that we all partner together. So we are really excited that Judge Furman partnered with Minna to create this short video, and I would really encourage you to watch it. So some of the recommendations that we had when we created our roadmap to Family First Prevention and Services Act is that we really think about how do we turn all of our state government agencies in a way that we're all working towards the same goals. So as many of you know, last year Senate Bill 108 passed, which is the Juvenile Justice Reform Act. So there is a lot of things happening on the juvenile justice side with new assessment tools. The Office of Behavioral Health, as you guys know, has the Behavioral Health Task Force, which our governor created, along with the COACT and the Children's Behavioral Health Work. So the Office of Early Childhood has a lot of changes that has happened. So we need to make sure that all of those things are working together in a way that makes sense and it isn't too overwhelming for our counties that are trying to implement this. So what does implementation look like? So this slide actually needs updated. So this was when we were initially going to go live in January 31st of 2020. Since that time, we have agreed to delay implementation of Families First until the spring of 2020, but this still does highlight things that need to happen. So we are going to need some statutory changes in Title 19, Title 24, Title 25, and Title 26, as well as some administrative rule changes, which for those of you that speak child welfare, that's Volume 7 rules that need to be changed. So We also, one of the things that are spelled out in the Act is that we have to provide training to our judicial partners. And so we've been partnering with the State Court Administrator's Office. The video is one of the results of that. So what we call this is really an awareness briefing. It's not training, but we really do need to provide some training to our partner to say, how will this affect all of them? We also have, as you saw on the initial slide, lots of work groups that are happening about the assessment tool, the neutral assessor, the QRPTs, the service continuum. So how is all of that going to work so that we can roll that out really thoughtfully for the state of Colorado? So here is actually a link to the Act, which you can go to. But before you do that, I really want to give Deidre some time to talk about the CANs, because this is a really important behavioral health tool, and it will be a huge part of implementation of Families First. So, Deidre.
Thank you, Tiffany. So I'm Dr. Deidre Godinez, a child and family researcher at the Office of Behavioral Health. I'm excited to tell you about our collaborative efforts with the Office of Behavioral Health, Child Welfare, and Healthcare Policy and Financing to streamline data collection for children and youth experiencing behavioral health challenges in Colorado. 30 years after the Colorado Client Assessment Record, or CCAR, was widely implemented, our data collection practices and methods have improved. Over the past couple years, I've been working with providers, youth, caregivers, and leadership to understand the needs, barriers, and strengths of data collection in Colorado. The feedback indicated one of the greatest opportunities for improvement was to streamline data collection by creating a common assessment tool that can be used across systems. This will reduce the burden to providers and family members while increasing the usability of our data. Since these efforts are across systems, this module has been designed to work with youth who are multi-system involved. As many of you know, Senate Bill 19195 outlines the need to create a standardized, a standardized screening tool and assessment tool. Also, with the Family First Prevention Services Act and our efforts to streamline and standardize data collection, this creates a great opportunity to build a standardized data system that works across systems. We chose the Child and Adolescent Needs and Strengths tool because it fit well with our vision. The CANs can be used for treatment planning, as an assessment of level of care, and with repeated measures to evaluate outcomes over time. Through the practice of transformational collaborative outcomes management, this tool provides the opportunity for an all-in-one process that builds collaboration and consensus across families and providers. The three main levels of Colorado's continuum of care include universal prevention and promotion, targeted intervention, and intensive intervention. Taking a closer look at intervention, targeted intervention is broken into outpatient behavioral health and enhanced outpatient behavioral health with care coordination and family challenges, which include youth involved with child welfare and the collaborative management program. Intensive intervention includes intensive community-based care and residential treatment. Residential treatment includes these out-of-home placements such as QRTP, whereas these intensive community-based care are really focused on keeping the youth at home and using processes or services like high-fidelity wraparound or day treatment. By utilizing a common assessment tool across this continuum of care, we will have the capacity to assess where our youth are falling through the cracks and identify targets for intervention as well as prevention. The rollout of this model will, of course, be slow. We will begin with the top tier, especially multi-system involved youth. Development will be evidence-informed through a continuous quality improvement practice and streamlined for the lower tiers. For the highest level of residential placement, an independent assessor will be utilized. All levels are done within the system of care values and principles and incorporate evidence-based and informed practices as well as crisis services throughout. It will be important to assess what services exist in each community so that all youth across Colorado have access to the least restrictive level of care they need. The system is designed to easily integrate with Colorado's current practices and programs and reduce the burden of data collection. It was also designed to use the skills and strengths of our youth, caregivers, and providers by building consensus and collaboration while contributing to the evaluation of programs and practices. This is the Child and Youth Assessment Tool paper copy. It's one page front and back. The items in gray are only required if those items are relevant for the family or youth, thereby giving us a streamlined assessment that prompts the additional items in gray if the needs of the youth increase. The first page focuses on the CANS items, including life functioning, caregiver functioning, youth behavioral and emotional needs, and strengths. The second page focuses on basic information and demographics we are required to collect, as well as traumatic and stressful life events and health questionnaires, which may be more appropriate as a screener. However, the design of the screener tool is still being designed. The CANS utilizes a scale from 0 for no evidence of need to 3, where the need is dangerous or disabling. For strengths, a 4-point scale is used to describe a strength that is well developed and a centerpiece to a strength that is not currently a strength. The idea is to have a single entry point, or at least single entry process, where a youth is referred. At this point, the standardized level of care assessment, which incorporates the CANS, will be administered, and a recommendation of level of care will be made. This is currently being developed as part of the Colorado Compass, a tool of the Office of Behavioral Health, but can be easily integrated with electronic health records and the Health Information Exchange of Colorado. A youth is either identified for a program such as High Fidelity Wraparound and a team can be built, or appropriately they receive a lower level of care. The pre-admission level of care assessment then becomes the baseline within 1 month. During this month, this assessment can be updated as you learn more about the client in that month's time. This will be done every 6 months. However, for the highest tier, which includes QRTPs, as well as some specific programs, this assessment will be required every 90 days. The Colorado SOC reference guide can be used to learn more about the CANS and specific items. The standard CANS comprehensive guide is also available for our most complex cases and easily integrates with our assessment form. Registration for in-person training is available at learn.coloradocsti.org, which is where you'll also find other trainings for trauma-informed care and resiliency. Our next set of trainings will be offered in the spring of this year. And hopefully by February, we'll be able to, oh, you probably want that. Hopefully by February, you'll be able to register for these trainings in the spring. All assessors must pass an annual certification for CANS, which can be found at tcomtraining.com. To learn more about the CANS or Transformational Collaborative Outcomes Management, visit prayedfoundation.org. I hope this was helpful. I want to recognize the contributions of many providers and families in the streamlining and design of this assessment tool, and also recognize that this is still work in progress, and I look forward to working with you all as we develop this further. Thank you for your time. I think we have some time for questions.
Yes, Tiffany and Deidre, this is Summer. Thank you so much for taking the time to share your expertise with us this morning. We really appreciate it. We do want to open it up for questions. We've had one question come in through the chat, which I'll read and then let you all answer. And then we can open it up to those who are on the phone. So one of the questions is for the QRPTs. In the future, will there be discussions about requiring agencies to provide appropriate services with those with comorbidities such as mental health and autism or mental health and IDD?
I'm not aware of that. I'm certainly not an expert in the QRPT. That would be Dennis Desperos, who's out of our office, but I don't remember seeing that in the legislation itself. So I could not say that that's part.
Great, thank you. Another question that came in on the chat, is there any kind of support through the state for current residential health providers who do not currently qualify as QRTP to transition into becoming a QRTP provider?
Yes, so our placement services team, once again led by Dennis Desperos, has been really doing some one-on-one coaching with many of the providers about what it takes, and they created actually a rule packet which was recently passed about what would have to happen in order to become a QRPT. So they look at their current licensing as well as what it would take for them to get to that. And so the placement services team out of the Child Welfare Division has a lot of training and support to offer.
Great, thank you. Can you share Dennis's email or contact information? And Tiffany, that's something if you want to share with me, I'm happy to send it out to everyone or add it to the slide deck before we disseminate it.
Absolutely.
Great. Is there anyone else with questions on the phone? You can, everybody is muted, so if you want to unmute yourself, just hit *6 if you're using your phone, or click the unmute button on your computer if you're using your audio computer.
This is Diane Primavera, and this all sounds really great, but are we concerned about a provider shortage for any of this? I know we've had workforce issues in a lot of other health arenas and behavioral health, so what are we doing to recruit more people into the fields that we need to make this a success?
So are you talking about the prevention providers, or are you talking about QRPT providers?
The people that do the assessments as well as the providers themselves.
So like I said before, one of the reasons that we actually are delaying the implementation of Families First is because that's something that we really need to figure out across the state of Colorado, is not only the assessment and who that will be and what that will look like, but we also need to be really thoughtful about how we're rolling out the prevention programs, because what we know in some of our most rural communities in Colorado is that they often don't have MSWs that live in their county. So Kit Carson County, I know, has 2 MSWs that live in the county at this time. And so how do we roll out an evidence-based program that has to be supervised by an MSW in a county such as Kit Carson County? So those are things that we really will be thoughtful about our implementation strategies around. The service continuum subcommittee, that's what we've been talking about for many months now, is how we get all of the different communities up to capacity, how we can build on some of our neighboring communities to help provide these services. So the answer is that it's a work in progress.
And clearly, we have a lot of work to do across the front, just on the workforce front. So we will, that is a topic we'll be diving into when the full task force and subcommittees come together next week as well, since there's been several work groups that have been working on that.
Perfect.
Let's see, we've had another question come in through the chat. How or will you coordinate with agencies such as HCPF for long-term care and waivers, et cetera, to include those wraparound services? They are also creating new assessment tools, so there's concern that more assessments could create barriers to care.
So healthcare policy and financing has been at the table since day one. So we have not only someone assigned to the implementation team from healthcare policy and financing, but they are also on every one of our subcommittees. And then the Division of Child Welfare is meeting with them every 2 weeks to talk about those exact things. So we are talking about the IMD exception. We're talking about the waivers that may have to happen. We have been talking about services that could be provided by Medicaid, because one of the things I didn't cover in the presentation is if the state of Colorado draws down Medicaid dollars for a service, then we can't draw down Family First funds for that, because that would be double dipping the federal government. So we need to be really thoughtful with our partners from HCPF to talk about how we draw down the most funds, whether that's through Medicaid or through Families First.
Great, thank you. Are there other questions from people on the phone? Again, don't forget to hit *6 to unmute yourself. Okay, it doesn't sound like we have any other questions. Again, Tiffany and Deidre, thank you so much for taking the time to be with us today, to share your expertise. We really appreciate it. And I think this has been really helpful, just informing some of the work and the conversations taking place within the Children's Subcommittee of the Behavioral Health Task Force. So thank you.
Thank you for having us.
Absolutely. And we will share the slides from today and the recording within the next 24 hours, and we'll let the subcommittee know when it's up. So thanks, everybody, and enjoy the rest of your day.